Wonderful. All right. So next is meningitis. Here's our antibiotic triangle of truth. Gram-positives first. Big offenders are strep pneumo, 30 to 60%. Issues in meningitis are that 40% are penicillin resistant and 10% are ceftriaxone resistant. Also in gram-positive, think about Listeria, only 5 to 10%, but if you're older than 50 years and you're an alcoholic, you're at risk for Listeria. Gram-negatives, Neisseria meningitis, 10 to 35%, as well as your H. influenzae, which you knew from your CAP, only 5%, but is also seen as a gram-negative bacterium. Troublemakers in meningitis for gram-positives. MRSA. You can see MRSA meningitis. It's rare. It's mainly after procedures or CSF shunts, but if you have a patient with a CSF shunt, you need to think about MRSA, or trauma with opening up to the meninges. Gram-negative troublemakers. Again, you can see gram-negative rods and Pseudomonas in immunosuppressed patients, Anaerobes. Don't see classically anaerobes, and you do not see classically atypicals. Okay, so how to come up with a good antibiotic regimen? Gram-positives. Ceftriaxone is a good bacterium and is cornerstone of treatment in meningitis to cover for strep pneumo. Just keep in mind that strep pneumo is mainly penicillin resistant, but also 10% ceftriaxone resistant. So vancomycin is normally added to cover for the ceftriaxone resistant strep pneumo. And then our Listeria. Patient greater than 50 years old, alcoholic, at risk for Listeria. Good antibiotic choice for that is ampicillin. All right? If you have troublemakers, gram-positive troublemakers, vancomycin, already mentioned up here. It's a great choice to cover for that. And for your gram-negatives, the Neisseria meningitis and the H. influenza, ceftriaxone, which was already mentioned here, are great options. Okay, so how to build an antibiotic regimen? Vancomycin, ceftriaxone is very reasonable, Covers against strep pneumo, also covers against the ceftriaxone-resistant strep pneumo, would cover against MRSA, and ceftriaxone covers against Neisseria and H. influenza, If it's 50 years or older, you want to add ampicillin, mainly just because of the Listeria, And if it's post-procedure CSF shunt or immunocompromised, you want to have definitely vancomycin on board, for MRSA, but you also want to change the ceftriaxone to ceftazidime, to cover for Pseudomonas. All right? Great, fantastic. So now you know how to pick the right antibiotics for meningitis and how to give a good reason why you want to use those antibiotics. Let's go through UTI or pyelonephritis. Our antibiotic triangle of truth. What's the most common bacterium in UTI or pyro? It's E. coli. So gram-negatives are really big. E. coli, 80%. Sometimes you can also see Proteus or Klebsiella, but mostly it's E. coli. Gram-positives are rare, I've seen complicated UTIs. Enterococcus can sometimes be seen, staph epi. All right? MRSA, you don't see that in UTIs. And Pseudomonas UTIs are extremely, extremely rare too. Anaerobes, not classically seen. Atypicals, not classically seen. So your big thing is obviously E. coli. What about antibiotic coverage? Ceftriaxone is a great choice. Covers against E. coli, covers against those other bacteria too. Other alternatives, in particular, if you have just a cystitis, meaning lower urinary tract infection, a urinary tract infection that only involves the bladder, does not involve the kidneys, patient has no flank pain, no fever, etc. You can also pick Bacterium and Nitro for your garden variety cystitis. But you would go with ceftriaxone if you have any suspicion of pyelo. Okay. Cipro, Levo also works well for E. coli. Cipro has been used a lot, okay, and we're seeing more and more resistance now against this bacterium. And lastly, against Enterococcus, augmentin unison are choices to use also against staph epi. Okay, so if you want to build antibiotic regimen, if you have an uncomplicated UTI, so meaning again, a woman, not a man, every man who has a UTI is a complicated UTI, okay, and a woman who has only a cystitis, no evidence of pyelonephritis, you can go with Bacterium, fluoroquinolone, or nitrofurantoin, and the duration is normally 3 to 5 days based on the antibiotic. If you have a complicated UTI, okay, either it's a man or you have evidence of pyelonephritis, so upper urinary tract infection, you normally go with your best choice, which is ceftriaxone here. You can also use fluoroquinolone, and normally 7 days for outpatient to 14 days inpatient.